Okay, I'm not just trying to make a public service announcement. I'm here with my parents, so we're all wearing masks.
Well, and the reason is today is Becky's birthday, so everyone wish her a very great happy birthday.
Thank you. I'm smiling. Thank you. So hello, everybody. I hope you can hear me. Glenn, give me the signal if you can't hear me. Glenn Grossman, our host, is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs in the United States and abroad. He currently is Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So with that, so good to see you all today. Okay, so thank you to everybody who sent in questions this week, and here goes. So Glenn, we usually start with, how are we doing since we've last been together? How is the country doing, and how fast is the epidemic growing?
Well, so we are in the middle of the summer here in the United States, and unfortunately the cases are out of control. Oh, I need to share my screen, don't I? And so, whoops, desktop, this is what I want. All right, so yeah, as you can see, the cases are out of control, unfortunately. We've had over 455,000 new cases diagnosed in the last week alone. We're approaching 500,000 a week. This is out of control. It's crazy. One thing that I can show you over here. So this is what's reported from the CDC, the numbers. They've started reporting a 7-day average in addition. But you can see that the numbers now on a daily level are far, far higher than the highest that we ever reached in the peak in April. Back then, one of the reasons, if you recall, that the dynamics were different was that it was very challenging to find tests and to trace. Hey, Beck, can you please mute all, except for me? And so it was very hard to find a test. So therefore, most of the testing was taking place in the hospitals. And so many of the cases, maybe 10, maybe one case was diagnosed for every 10 infections, every 10 new infections that were happening.
Excuse me, you need to make me a co-host, otherwise I can't.
Okay, I shall do that. Great. And so yes, if you recall, so back at this point in early April, we were looking at approximately one diagnosed case for every 10, maybe, give or take. I mean, there's a lot of uncertainty there. Now we're approaching, it's maybe one for every 4 or 5, but possibly as many as 10. And so we're getting back to this case, to this situation where there's not enough testing going on. It's out of control. Much of the spread is taking place among people who are not diagnosed. And so whether they have symptoms or not, whether they're pre-symptomatic, asymptomatic, or they have symptoms and it's summer and they're just not paying much attention to it, a lot of the spread right now is not being diagnosed or tested or traced. So it's not just a matter of testing, but tracing. When you look at the numbers, so the first time that we reached above 40,000 cases per day, diagnosed cases, again, not infections, diagnosed, tested, test positive cases. This was June 26th. 6 days later, we got above 50,000 cases. That was July 2nd. 8 days later, we got above 60,000 for the first time, and that was July 10th. Now, 7 days later is when we hit above 70,000 for the first time, and this was July 17th. So with great confidence, we can probably predict that within another week or so, we're going to be above 80K, and it is going to be very hard to slow this down, to prevent it from hitting above 100K new diagnosed cases per day before the end of the summer. So we are not on a good trajectory right now. The major problem now, and this is the reason why I keep saying that I can't see any way that we can avoid going under lockdown. The major problem right now is that even if we were to get the R to 1, so I guess if we look at this as speed versus acceleration, right now we're still accelerating. Our foot is still on the gas pedal for this thing, and we're still going faster and faster and faster. If we were to just take our foot off the gas pedal and just continue having 70,000 new diagnosed patients per day, this is too many on average. So if this were to flatten, there's still so many that this was going to cause a massive number of deaths in the United States. And the only way to start rapidly getting this curve down is to have a lockdown. And so right now, with everything you've been hearing, where they're saying, oh, okay, close the bars and the restaurants, people should wear masks, and all the guidance that they're giving, there's still 70,000 new patients per day on average over the past week. Obviously, you see that it goes up and down and there's noise, but the direction is quite clear. Another way of looking at this, so this is daily new diagnosed cases. Another way of looking at this is the cumulative number of cases per that they've diagnosed since the beginning. Let me get this down here. And so you can see that the time, if you look at the time that it took to go every 500,000 new diagnosed cases, it took 40 days to diagnose the first 500,000 cases. Then it only took half that to diagnose 1 million, so the next 500,000. The next 500,000 took another 21 days, so it was roughly the same. The next 500,000 took around 24 days, so slightly slower, but then it started speeding up again. You can see this inflection point. And so then the next 500,000 patients was 17 days. Now look at it, the next 500,000 patients diagnosed was only 10 days. And now the most recent 500,000 patients diagnosed was 8 days. So this is getting shorter and shorter. And like I said, we're talking about the gas pedal. So we're not even talking about putting the foot on the brake. This is just trying to get the foot off the gas pedal at this point. And so this is a real serious situation that we're looking at. And the leadership of this country is not treating it with the severe, profound, historic severity that this is going to be causing. And this is not just causing individual crises for all these people and their families. This is impacting the economy. This is impacting all sorts of other things, other health consequences. People still are being diagnosed with all different kinds of diseases. And when SARS-CoV-2 is so widespread, it impacts the ability to treat and diagnose and address all of these other diseases too. So it's very problematic. Interestingly, so this is another way of looking at the total number of newly infected. So up here you saw, or just now, I said that we had roughly 455,000 per week. It's approximately 70,000 or so on average over the last, so this is July 17th, it's currently July 19th. It's dipped a little bit, but you see that we've hit the we've surpassed the 70,000 per day number. This is the estimate from a model that I like, that's estimating that we're around 350,000 new infections per day. So only a tiny fraction of those are therefore diagnosed. But interestingly, if you look, in fact, I can go to the specific website. This is COVID-19projections.com. Give me 1 second.
All right, Glenn, are you ready for me in the next question?
Give me one second and I will start again. Give me one second. I just wanted to finish this up. So one thing that you'll notice here is that this machine learning is projecting how many new infections there are going to be. And you see that it's projecting right now that we're near our peak. And the reason it's projecting we're near our peak is because it uses artificial intelligence. And artificial intelligence looked at the previous peak back in March and April to predict what our current new peak would be. And the problem is this old peak was under lockdown and the new peak is not under lockdown. So this number is just going to continue to go up and this model is just going to continue to change. So don't look at the future projections. This is just the nowcast that people sometimes call it in terms of what the numbers are. But this number is likely to get much higher because again, the model is based on the earlier behavior, and the earlier behavior was lockdown. And we are currently not under lockdown in most states, and so we are in trouble. All right, Beck, you can go ahead.
Thank you, Glenn. Always very helpful to see your graphs and charts. I hope you all don't hear an echo here.
There's a little bit, but that's okay.
Okay. Dad, lower the volume a little bit. Thank you. Okay, so isn't it a good thing that the average rate of infection is low? It seems to be keeping the average age of infection. Isn't it a good thing that the average age of infection is low? It seems to be keeping the death rate low, let's say in places like Florida.
All right, so it's a very good question. I think a lot of people are asking it. So if the death rate is low, or rather, if the infection fatality rate is low, then who cares if a lot of people are getting infected because there's not much problem with that. So there's two issues with it. First is that, so I think that it's actually worse for us that the age is low now, because as a result of the age being low, most people are not stressing out about it, and so the numbers are increasing. The problem is every single one of these new diagnosed patients or the infected people, every single one of the newly infected people are now going home and infecting their households. And so if we look at Florida as an example, so early on, back in March, the average age of infection in Florida was 65. Now, over the most recent set of new infections in Florida, back in the beginning of July, the 7-day average, the age was around 39. So if you go from July 5th and the 7 days after July 5th, the average age was 39. Beck, can you mute all, please? Becky, can you mute all? Okay, good. All right, and so now it's jumped. The average age of infection in Florida was 39, and over just a couple of weeks, the average age has jumped up and is now it's not jumped up a lot, but it's now age 41. And based on this idea that it's now people are infecting their households. If you remember back in March and April, the primary source of infection, when patients would come to hospitals, they'd say, where were you that you got infected? And the primary source of infection was households. People said that they were infected from people in their households. So now these numbers are about to shift. And so we're going to see a lot more people in their households who are going to get infected from the other people who live with them. And so now this is problematic because we have so many daily new infections. We are about to see a problem. Before the end of August, we're going to see the deaths rise dramatically. In fact, we're already starting to see that. So if you look at some of these numbers, in fact, let me jump to here. So if you compare the death rate, if you look at some of the leading states, so Arizona, California, Florida, South Carolina, and Texas, these were the ones that had the big outbreaks for earliest. If you look at these, you saw that there was an exponential increase in the daily diagnosed cases. And at first, we weren't seeing this new increase in deaths. But now what we can clearly see is an exponential increase in deaths. And I just wish in some ways that we had had this earlier signal, so people were scared out of their minds and not going outside. But because the infection fatality rate was low at first, and in some of these other areas is currently low, then there's no signal in the population to realize that this is a crisis. It's like a train wreck and people don't realize we're on the train and the tracks ahead are off. And so you see this exponential growth. This is going to continue to cause major problems, particularly as the average age of infection is now going to rise, like I said, because it's mostly going to be within the household that a lot of the spread is happening. And to that point, just one more thing to add there. If all of these states were to lock down now, like today, you would still see a dramatic increase in daily new cases because they'd be infecting the household members, and you'd also continue to see a lot of an increase in the deaths because of people who are sick now who are going to become more severe and then will die, and also because higher risk people are now increasingly being exposed through the household again and through friends of friends. And so you see here where Alabama, Georgia, Louisiana, Missouri, North Carolina were a little bit later to the game here, and now you just are beginning to see the death rate to start. But there's nothing, it's out of control, so there's nothing that's stopping it from going up. If there was a lockdown, then we would expect it eventually to start going down, but right now there's nothing that's right now, as I'll keep saying this again, we still have our foot on the gas pedal. And so it's not even a question of putting our foot on the brake, which would be a lockdown. We're still just trying to get the foot off the gas pedal. And so even if it's off the gas pedal, we'll still be coasting at a really high daily infection rate, and it's only going to cause a lot more deaths. So it's not something I don't see it as a good thing. I see it as just the opposite. That the society is not getting the signal that this is an issue, because a lot of people are not dying right now. The low risk people are getting infected, but there's no way to stop them from infecting others. And so it's going to be problematic. All right.
So Glenn, we see, excuse me, hold on for one. We have a little bit of surround sound here. So Glenn, I guess in the immediate term, the best thing we can hope for is that more people wear masks. And Sandy Rock had a great question. Sandy, I am going to unmute you so you can ask your question about masks. And hold on one second. I'm going to unmute you about masks. And maybe before, actually, there you are. You're unmuted. And maybe also, Glenn, you can answer why it took so long for people to realize that masks were effective. Okay, so Sandy Rock, I'm going to get over to you.
It's really a two-part question. The second,
muted.
Glenn, can you hear me?
Can you mute everything except Sandy Rock, please? Yeah, I can hear. Oh, but unmute. Now you're going to have to unmute yourself, Sandy.
Oh, okay. I am. Okay, you're there, Glenn?
Yep, I can hear you.
Okay. I live in an area where it's a real dilemma, where people are of the ilk that they need their freedom rather than safety for everybody else. And my question is, assuming that with governors suing mayors who want safety for their constituents, crazy, crazy things, assuming that this might continue. I mean, President Trump just today was saying again that it's a question of people's freedoms and he's not going to have a mandate. Can we make it until November? Let's assume there won't be a vaccine. Maybe there could be some more treatment. Can we make it to November? And then we have to make it until January, assuming there's a change of leadership. And what will these tables look like then? And I also have I'm going to mute myself. You can answer that. But I also have a question about, is a mask a mask? A rose is a rose is a rose. Is a mask the same? And I know, aside from N95, I have a question about masks, but I'm going to mute myself, okay?
Okay, sure. So the first question is, can we make it until November? I mean, of course we can make it. It's just what the country looks like. I think that you can see the hospitalization rates. If you just look at the South, which is typically thought of as a very red area in terms of pro-Republican, pro-Trump, you're seeing that the hospitalization rates are starting to go out of control in many areas. So for instance, look at Georgia, South Carolina, Tennessee, Louisiana. There's a lot of rapid growth in hospitalization, and there's nothing stopping these things. Masks alone aren't going to cut it. The only thing masks are going to do is take our foot off the gas pedal. And so it's still not going to put the brakes on. And so the only way to really aggressively put the brakes on is a lockdown. So even at the rate that we're going, if we were to keep the foot on the gas pedal, then the rate of acceleration would just get faster and faster and faster. If all we do is take our foot off the gas pedal, then we're just going to continue hospitalizing people at the same rate that we've been hospitalizing them, because we'll just continue cruising at the same rate. And so that means that we're going to see trouble. I mean, you know, epidemiologists have been warning about this for months. This is not rocket science, as people like to say. It's just very straightforward epidemiology, stuff that we've known for decades, if not centuries. And we think that the rules have changed suddenly, and that epidemics are sort of just, if it feels like the flu, it must be the flu, and that's just not the case here. So what will it look like? I mean, it's hard to predict if they lock down. I think that there's a lot of resistance to lockdown. One thing I'll add, so we haven't talked about this. So over the past week, the federal government decided to make a massive change. And I didn't put a slide on this, but I'll talk about it just briefly. So the federal government, so typically, one of the key aspects of epidemiology, I mean, the whole definition of epidemiology, the textbook definition is epidemiology is the study of the distribution and determinants of disease in human populations. And so studying the distribution of disease is sort of one of the core elements of epidemiology. And that another way of saying this is surveillance, understanding where the cases are, what the distributions are, where are the outbreaks, what's going on, where is it going. And the CDC has been the world leader in surveillance for health, in diagnostics and all sorts of things. For this epidemic and this global pandemic, the US CDC has really not done well, but it's not doing extremely poorly relative to what it could be doing. And so, for instance, surveillance could be much better, but at the same time, it's been consistent. We know how to interpret much of what they're doing, not a lot. I mean, so some of the testing dynamics, it's still a little bit uncertain. And so there was room for improvement. The problem was the numbers were getting really bad. I mean, as you see these hospitalization rates, these are not things that Trump wants anyone to see. And so what the Trump administration has done, what the Republican administration has done, is they've decided last week to remove the CDC from doing surveillance in the United States anymore. And so now what they've done is they've hired a private company who most people know nothing about. We don't know, will we be able to access the data in the same way? We don't know anything about them. It's through Health and Human Services. They have no history in national level or sort of aggregating data at the national level and collecting it from counties across the United States to sort of set up a new data collection system and reporting system. So typically something like this takes many months, maybe years, to develop the construct of what it's going to look like, to build it out, to run trials on it before you even begin collecting data. The problem is they've already switched, as of this past week, to this new private company now. And so it could really fail. And if it fails and there's a collapse of the data collection system, then that might be what the Trump administration is looking for, because then now we're going to have a much harder time getting data. Already many of the dashboards that people are using, it's unclear what data is out there, what's the most accurate source. Now there's disagreements across dashboards, and it's a real mess, the data collection. This is real 1984 level of stuff, where it's an authoritarian government, where if they don't like the message, they're literally changing the data so that people can't see the data of what's going on. And that, I don't know what that's going to look like before November. We don't know what the data is. So what's reported to us, we won't know if we can trust it. Is it just something in the system? If some data feeds from some hospitals aren't coming through, they're most likely going to be reported as zeros. They'll just be missing, and so we won't even know that they're not there. And so the numbers might seem like they're much, much better, when in reality, we just don't have the full report of what's going on. So, so this is a problem. The thing is that with hospitalization rates, like in Georgia, so high, they're going to have the same experience. They're already having the same experience that we had in New York City and New Jersey, where we personally knew a lot of people around us who were going to the hospital, who were getting infected, and who were getting severe disease or dying. We knew, because there were so many people getting impacted, it was impossible to not be aware of people around us who were getting sick and who were dying. Friends of friends or whatnot. There was just a couple of degrees of separation, and you were aware of it. That's going to be the same thing that we're going to be seeing in the South. Regardless of what's reported in the news, people are going to be hearing about friends of friends who are hospitalized and are dying. And that's, we will see, there's no way to avoid that before November, because we're already starting to see that. So what's going to happen between November and January, I have no idea. There's a lot of dynamics in play. The politics, I have no idea how to predict that. It's all like, I mean, the big questions I'd be asking. So if the economy is really in trouble and shuts down again because of some lockdowns, then will there be another stimulus bill? That's a political question. I have no idea what that will look like. Will there be motivation to lock down or not lock down? I have no idea what that will look like. There's a lot of these political questions. I don't have any insight into that kind of stuff. Did that answer your question for that?
It did.
Sure.
It wasn't the answer I would have liked, but I knew what it was going to kind of have to be. My other question is a little bit aside. When we talk about masks, I know that there are different fabrics that, aside from an N95 mask, I know that there are different fabrics that are available, and some are much tighter, like batiks are much tighter woven than others. Is there anything that we can do to protect ourselves with a better mask short of an N95? I mean, I'm even looking at Becky's surgical mask. The sides are open. I mean, do we need to be that concerned?
Yeah, it's a really good question. So let me talk about masks more generally, and this in particular. So first of all, there was this question early on in terms of whether we should even wear masks at all. You remember there was a debate, and the reason was, essentially there are three different kinds of ways of getting exposure that we typically think of for this disease. The first way that we think of is if there's droplets when we breathe out or when we cough, that there's droplets of the virus that can go and spread. What's interesting about a droplet is it doesn't go very far. Within 3 feet, all the droplets would have essentially dropped down for the most part. And so that's why we thought, well, 6 feet distancing will be likely to eliminate most of that risk, because if it's a droplet-based spread. If it's an aerosol spread, then that's not a droplet. That's much, much smaller. And the problem with aerosols, like a hairspray aerosol, is that it gets in the air and it just stays there. And if something is aerosolized, then if you have a fan, then all that happens is the fan could spread it across the room, and someone across the room could get infected. And so then aerosols are a very different type of question, because then most masks would not protect that. A fabric mask would not protect from aerosols. A fabric mask would protect from the droplets. The third way that people were afraid that we would get infected was by touching it. So if you coughed into your hand and then shook someone else's hand, or touched your face, or touched their face, or touched a doorknob and then someone else touched the doorknob, then the touching part would be the way that it was spread. And the masks are not good at protecting that in terms of people getting infected from touching something. Because typically when we touch something, then the masks are irrelevant. we have an itch, so we touch our skin, and then it's on our cheek. And then when we take the masks off at night, then it's still on our cheek, and then it's easy to get into wherever else it might get infected. And so then the biggest question early on, because we didn't know what the major path was for spread, was it a droplet or an aerosol or by direct contact? We didn't think that masks were necessarily going to be helpful, because we worried that if people wore masks, then they would let their guard down. And that if it was aerosolized, it would not be as effective. And that if it was something that was transmitted via physical contact, then it would not be as effective. And people would assume that they were bulletproof because they were wearing a mask. And so that was the big controversy early on, why we should maybe not promote masks. The other reason why masks were not promoted early on was because most states were under lockdown. And so there was a shortage of masks, and we needed to ensure that all of the hospitals and physicians and treaters had masks they need, so that they would not get infected themselves, and we'd have a shortage of HCPs because they were all got sick from COVID, or that we wanted to ensure that they were not getting other patients sick. If someone came in with a heart attack and did not have COVID, then we had to be sure that they did not get COVID in the hospital. And that would be what we call iatrogenic transmission of a disease. So that's when a physician gives it to somebody else. And so in this case, we needed to ensure that we gave all the spare capacity of masks to our hospitals. And so that was another important reason why we're not emphasizing that the general population should be wearing masks. Now there's been an accumulation of evidence. There's guidelines to wear masks, and just because there's a guideline or even a requirement to wear masks does not mean that everyone wears masks. It only means some people wear masks, because there's speed limits on the road. Say it's a 55 mile per hour speed limit, and people speed all the time. That's why we have enforcement. And so even if there's a guideline, it doesn't necessarily mean it's going to be enforced. And so as you can see, this was just an article in the New York Times. They've been doing some really good research on their own. And this was looking at people wearing masks around the country. And these dark areas are where people are much more likely to wear masks, and the light areas are where people are much less likely to wear masks. And so you see in parts of Florida, there's a lot of mask wearing, but in parts of Florida, there's hardly any mask wearing at all. Similarly, in much of the South, there's not a lot of mask wearing. And this is just over since the beginning of July, just the last couple of weeks. And since July, this has been exploding in Florida and exploding in the South, and yet people are not wearing masks. You see that these are some other areas where they are wearing masks, but the problem is that even if you have a requirement to wear masks, people are still going to congregate in their own homes, bring people together, and they're not wearing masks, and it's problematic. When you compare us, the United States, to other countries, you see that we're not doing so poorly relative to some others. So we're doing better than Taiwan and France and Canada, for instance, but many other countries are far ahead. So we could be doing better because we know that a lot of other countries are doing better, but we haven't gotten there yet. And the main reason, this is, most epidemiologists will agree on this, that the main reason that we're not currently succeeding in getting more people to wear masks is because we don't have support from the senior leaders at the top of the country. The federal government is not sending a consistent message. There's variation. Some people are saying, yes, we should be wearing masks. Others are saying it doesn't matter, or from the beginning they were saying they weren't wearing it, or we saw inconsistent messaging. And when you have inconsistent messaging, this is what you see in the country. You have inconsistent adoption of the intervention that we're looking at. And so, yeah, it's a problem. That's what we're seeing here.
So, Glenn, is it safe to say, perhaps maybe, that the one bit of good news is that we're getting closer to herd immunity because of all of these outbreaks? Could that possibly be a bit of good news that you could share? And
yeah,
I'm going to listen
unfortunately.
to that good news, and then I apologize. I need to log off, but I hope you can maybe turn some of this into some good news for us.
Well, unfortunately, so right now there's two different aspects of the immune system that are thought to be really protective. So one is a typical antibody response, that's thought to be protective. And an antibody, the way that it works is it attacks the virus directly. So if you recall, a virus infects a cell, and it requires the cell's machinery to reproduce. It can't reproduce on its own. And so when it infects the cell, then it takes over the cell's machinery, it makes copies of itself, and then releases those copies either by destroying the cell or keeping the cell alive, but then just keeping on churning out other copies of the virus. And then when the virus then enters the animal through the bloodstream or through the system, then the antibody can then attack the virus directly and either could be a neutralizing antibody and prevent the antibody from infecting any other cells, or it could just pull the virus out of circulation and be processed by the body's immune system. So that's the way an antibody works, focusing on the virus itself. In contrast, T cells identify cells that are infected. So when a virus infects a cell, then the cell sends out a warning signal that it's being attacked. And so then the T cells come and they find the cells with that warning signal, and then they destroy that cell, and they pull that cell out and destroy that whole cell. And so because of that, then any virus that might be in that cell is then destroyed. And so that's another way that the immune system works. So it doesn't necessarily destroy the virus itself. Instead, the T cells destroy the whole cell that's producing these viruses and takes it out of commission. And so it's really another effective way of preventing the viral spread. Together, these two approaches, the antibody and the T cells, work in synergy to stop infections. And so we are seeing that T cells have these memory, the memory T cells have persistent memory that's longer than the antibodies. Unfortunately, the antibody persistent immunity, and we still don't know if it's truly providing protective immunity. This is still an open question. But if it is providing protective immunity, unfortunately, we're finding that the antibodies are disappearing from people very rapidly. Some antibodies stay for many years. So for instance, if someone got a polio vaccine when they were a kid, that could protect them for many, many, many years. In contrast, if someone gets infected with SARS-CoV-2, it does not look like it's going to be protecting us for many years. It looks like in some people, the antibody response actually fades within 2 to 3 months. And so we don't know how long it's going to last for most people, but the fact that some people are already losing their antibody response within 2 to 3 months is quite worrying, because then it means a year from now, we might be in a similar situation among people who are infected, that they no longer have protection. And then the other worrying aspect is our vaccine program. And so many of our vaccines, the way that they work is they stimulate the body to interpret it as if it's under attack. Then the body creates its own antibodies without being actually infected. But if the antibody response is not very long, only lasts 2 to 3 months, then it may be the case that many vaccines that we make are not going to have an effect longer than 2 to 3 months. And if that's the case, we might need to have booster shots every 3 months, every 6 months, I don't know. But the problem with this is that as many doses of vaccine as we have, now we might need to double, triple, or quadruple it per person in order to maintain this effective protection. And so this is another area of uncertainty that we're trying to track. The T cells, the problem is that right now we have antibody tests. We do not have any widespread T cell tests to understand what the T cell memory looks like at the population level. And that's because it's a much more expensive, much more involved type of analysis you need to do to evaluate people's T cells. You can just do, for an antibody test, you can just do a binding test. And so it's almost like a strip of paper, like a pregnancy test almost, where it's a strip of paper that you're testing, just a binding test. Whereas when you're doing something like a T cell analysis, we don't have any sort of quick rapid tests developed yet to evaluate this. And so this could be, it could be a source of protection, but it wouldn't necessarily be something that's evaluated as part of our vaccine trials. And if it does have an effect, it's not something that we're measuring regularly in the population. So it's problematic. This is another reason why we should be locking down, because we don't know what we don't want to have this active level of infection continue for many years into the future. Right now, there's no sense that herd immunity could stop shortly. All right, so let me see, Becky, it sounds like you dropped off. Let me just check. Yes, that's okay. So I'll just continue with some other questions that we had. All right. So last week we talked about reopening schools, and I mentioned that there was still uncertainty over whether kids can infect others. And we showed that there was this study in Israel, or case study, where there definitely were outbreaks associated with kids transmitting the disease. And this would be a worry of reopening schools, because even if the kids themselves aren't impacted very much because their risk is personally very low, if they increase the risk for faculty at the schools, for staff, and for families and community members, then that would not be good, because kids live with parents and grandparents. And so then you could very quickly be causing an even more massive outbreak than we currently have, more widespread across the country. And so this would be very problematic. There was just this new large study that was just released by South Korea, one of the best studies to date. And what makes it great was because it includes massive contact tracing. So for every person that was infected, they were able to find out who infected them and who did they possibly infect. And so because they were able to link all of the contact tracing together, they could say with authority that children younger than 10 transmit to others much less often than adults do, but they do transmit some. So there is transmission that is occurring, and that those between the ages of 10 and 19 can spread the virus at least as well as adults do. So that means that we're essentially putting kids, at least from the age of 10 to 19, into petri dishes where they're going to be infecting each other, and then it's going to potentially be a massive spread in the population. So it's potentially very problematic. There was another study here that I thought was kind of interesting. It's hard to see. I'll see if I can make it a little bit bigger. But so basically they were able, through contact tracing, they found one person, that's this A0, this index patient. And from this one patient, they were able to trace all of the other people that were infected from that one line. I keep on talking about infections. So viral infections, we need to be thinking about them as chains of infection. When any person gets infected, it's not just a question of their own personal risk. In many important ways, a more important question is who is going to get sick behind them. Who do they infect? And then what's the chain of infection from that? And so this one person might have been okay. I don't know if they ended up living or dying. They might have been okay. But the problem is there were 70 other people identified as this chain of infection from this single index case infecting one other person. So from this one first case infecting one other person, over the course of weeks, they ended up infecting 70 other people. And this is what we need to be afraid of, because it's not just a question. So when we talk about 70,000 new diagnosed cases per day, these 70,000 new diagnosed cases now are starting new chains of infection behind each of them. And there's no way to avoid that. Even if they don't increase more than one, even if they get it, so it's just on average, one person infects one more person, infects one more person, then you're going to be having 70,000 infecting 70,000, infecting 70,000. And when you look at these, the gray are the confirmed cases, and the white ones are the carriers, the asymptomatic carriers. So there were a lot of people infected here. I don't know if it says clearly the number of deaths that resulted from this one person, but there were some deaths associated with the first person. So we have to think of this as a chain of infection, as a disease that's not about our personal risk. So for instance, it's not about riding a motorcycle and choosing for ourselves whether to wear a helmet or not. This is our choosing whether to infect and potentially kill other people around us. And that's something we need to be aware of. Another thing associated with this, I've been really hard on the CDC over the last few months for some good reasons. They really have made some mistakes. they could be doing a lot better. One area that they just started doing better was they had, since March, April, they had been assuming that the infection fatality rate was extremely low. So the best sum of evidence was estimating based on the sum of evidence that the adjusted infection fatality rate was likely to be between 0.5% and 0.78%. And so it was pretty consistent across it. It did vary across different studies, but the best sum of evidence, when you took all of the evidence into account, was roughly 0.5 to 0.78. And yet the CDC was communicating that the range was 0.1% to 0.8%, and that the best estimate was 0.26%. So again, the best sum of evidence going up until currently is at 0.64, and they were saying the best estimate was 0.26. Not based on evidence, just based on their own conclusions. And they were using this study, which was just some random guy in California, and it was very, very poorly conducted. But so here's some good news. Well, I don't know if it's good news. The good news is that the CDC, as of July 10th, has updated their infection fatality rate. And their infection fatality rate that they're now using in their models and now using for their communication is 0.65%. So ranging between 0.5% and 0.8%, which, as it turns out, is the sum of evidence that we've known for several months now, or not several, but maybe a couple of months now, we can say that the best evidence is saying it's approximately 0.5 to 0.78, with the estimate, with the average being around 0.65%. So the CDC at least is catching up. They're doing good work. They're using the evidence now to report what's going on. Unfortunately, when they made this update, they did it silently. So the country was mostly not aware that they've just doubled, essentially, more than doubled the infection fatality rate that they were using for months to now with the most reasonable evidence-based approaches. And so that is what it is. But so now at least the CDC, I think, is more trustworthy, even though now they can't report the data. They can't do the surveillance that they were doing. But at least now they're getting on board with the evidence. A couple of other things. Let me jump. One open question that I have. We're thinking about this disease. We're thinking about COVID as an acute disease. So basically the idea is that you get the disease, you incubate it for a little while, then you either get symptoms or you don't get symptoms, then you get sick, and then it resolves. Within 2 weeks, for the vast majority of people, either you fully recover or you die. And that's the general thinking that most people have, that it's just a very short-term disease. Then we know that there's some exceptions, and some people who get severely ill do stay in the hospital for maybe weeks longer. Some people we've heard about have symptoms for maybe months longer, but they seem to be a minority. What we don't talk about is acute versus chronic disease. And so there's a major issue here that we don't know. It's still uncertain. We don't have a good answer here yet. And so this is just an uncertainty that everyone needs to be aware of. And that's this. So when we do the viral test to see if someone has an active infection, what we're doing is we're testing spit, or we're testing the back of someone's nose or their throat. We're testing those local areas. The problem is, if someone has a negative test there, it does not mean that they have a negative test in other parts of their bodies. So for instance, we know that anywhere there's an ACE2 receptor cell, or a cell with an ACE2 receptor anywhere around the body, we know that SARS-CoV-2 can infect that cell. And so that's why there's all these crazy other symptoms that are involved. There's nervous system symptoms, there's gastrointestinal symptoms, there's all the clotting that's involved with the cardiovasculature system that has ACE2 receptor cells there. And so the problem is, there could be active infection in the cardiovascular system with the ACE2 receptors there, but we're not testing there. The nasal swab is only testing the nasal area. And so right now, we don't know if there's chronic disease going on among people who were infected months ago. We have no tests out there right now to know if there's a chronic disease. And this is potentially very problematic. we've been in a crisis. And so the crisis is focusing on the acute. And obviously, lung damage and death are very clear, quick things we can see. But we don't know if the disease is chronic. What we do know so far, there's been this question of reinfections. And what we have been following are that there are clearly examples, many examples, of people who were infected, then they have multiple negative tests, and then a month or more goes by, and then they test positive again consistently, and their symptoms come back, and they are positive again. And those cases have almost all been demonstrated to not be new infections. It's the same person where the virus is reemerging. And so for me, this demonstrates a proof of concept that we now know that there is underlying disease that is continuing in at least some portion of the population, and we don't know how many that is. Right now, we don't know what the distribution is. We don't know the level, the prevalence of the population that has this chronic form. We don't know what it means to truly clear the virus. One thing that we've known, so one of the big problems is that there's a difference between viral shedding, and that's when RNA is found and through the PCR test, versus viable virus. And what we've realized is that a lot of the virus that's found in the viral shedding is non-viable. And so that means you cannot infect others if it's non-viable. But what we found is that, so in the gastrointestinal system, if you test feces, there have been viral shedding that's found there. And what's been found is that sometimes the viral shedding in the feces lasts for at least a month after viral shedding stops in the lungs. And so we know that it continues on. We just don't know the distribution. We don't know how many people it impacts. We don't know if it varies by age or ethnicity or comorbidities or anything. We're still in the dark here. And we need to treat the disease with the respect that it deserves, that there is so much that we don't know. And when we're talking about 70,000 new patients a day getting diagnosed with this as a new infection, we don't know if some of these patients are now going to be chronic disease carriers of this disease. And we just don't know what it looks like. So this is a serious concern, and we're still in the dark about this. An example is hepatitis B. And so I just wanted to talk about this briefly. So hepatitis B is a DNA virus rather than an RNA virus that we're talking about. So it's double-stranded. Like SARS-CoV-2, it has some it has some spikes, not the same kind of corona spikes, but it has some of these proteins that stick out. And so the proteins that stick out are called surface antigens, and antibodies can respond to the surface antigens, but then also in the chronic form of the disease, the virus bursts open during some of the processes by the immune system, and then there's all of these proteins inside. And so if the body can't get the virus under control with the surface proteins, then as a last-ditch effort, what it tries to do is it creates antibodies for some of the proteins on the inside. So then if the virus is exposed, then you might be able to help to constrain some of the viral replication if any of the internal proteins are identified. And it's not efficient, and what happens is you have a chronic form of the disease. And so for hepatitis B, many people clear the disease, and so the acute form, many people clear the disease, but many people also have a chronic form of the disease that stays with them throughout much of their life and then causes long-term consequences. So it could cause fibrosis of the liver, cirrhosis, might require liver transplants, and for many people, ultimately, decades after having this chronic disease, they end up with liver cancer or early mortality. And so that's different than an acute mortality, but it's still early death, where instead of a normal life expectancy, they're dying for many years, if not decades earlier than they would have because of the chronic form of the disease. And again, we don't know yet if SARS-CoV-2 has a chronic form that we need to be worrying about. We're in the dark about this question. The difference between when these things were found, so viral hepatitis was first identified in 1885. In 1963, the surface antigen was discovered, and that the guy who discovered it, Baruch Blumberg, was awarded the Nobel Prize for this discovery. Then, less than 10 years, but multiple years later, it was called the Dane particle at the time, was the core antigen. It was identified. And then another one a year later, rather 1972, sorry, rather than 1972. But you see that there's a long period of time to find the science involved in this disease. And so some of the science has been lightning fast for SARS-CoV-2. But science takes time, and it seems like the last few months, like 10 years have gone by in terms of the amount of time in terms of what it's felt like. But science takes time, and some of these things we still don't know. These are major critical questions, and we still don't know the answer to them in terms of what the long-term natural history of this disease will look like. Another thing I wanted to talk about briefly before I end it is, we talked about this one, is age. All right, let's talk about this. So life expectancy. So one thing that I've heard come up a couple of times talking with some friends is that they said, well, you know, it's mostly older people that get it. People over the age of 80 are the most likely to get it, and people who are above the life expectancy. So the life expectancy among people who are 1 year old, the average male is going to live until 75, and the average female at age 1 is going to live until 80. But so it's a misinterpretation is what I'm getting at here, in terms of thinking, well, it's mostly people over the age of 75 who are getting sick and dying, and people who are men, and people over the age of 80 who are female who are dying from this disease. But that's not a good way of looking at this, because the reality is that a lot of people die before the age of 75. So this is the average age. So if you then look at males who are age 80, so here's a life expectancy table. Down here is age 80. The life expectancy of someone at age 80 is actually 9.68 years more if they're female, and 8.28 years more if they're male. So that means an 80-year-old on average is likely to live to 88 or more. And then as you keep on going older, then the number of years of your life expectancy keeps on going up and up and up. So that means if you're at 80, so we said here it's an 88, the average person who's 80, who's a guy, will live to 88. Okay, well, let's go to 88. Okay, well, now the average 88-year-old will live an additional 5 years. So then put another 5 years on that. Let's go to 93. Okay, a 93-year-old on average is going to live an additional 3 years. And that's because if you're generally a healthy person at any given age, if you're an 80-year-old who's generally healthy, then the average number of people who are 80-year-olds, the 80-year-olds include a lot of people who are very, very sick. These are people who are almost at their deathbed. And so that means that when you look at the average, there's a lot of very healthy people who are going to be living much, much older. And so when we're looking at all of these people who are age 65 and over, 70, 80, 90 and over, who are potentially at risk of getting this disease, just because they're that age doesn't mean that their life is about to be over. An 80-year-old, on average, just because they're above the life expectancy for a man, the life expectancy was 75, but the average 80-year-old is going to live an extra 8 years if they're a male, an extra almost 10 years if they're a female. So I mean, we have to really be very careful, because the ones who are getting sick and dying mostly from this disease are the ones who are ambulatory. That means that they're walking around and getting infected. The ones who are locked down and are isolated are not getting exposed. Those are not the ones who are likely to get sick. In fact, in nursing homes, it was an interesting question that I had. In that nursing homes, also within the nursing home, they have a variety of people living there. Some people never get out of their beds; they just stay in their beds full time. And some people walk around and go to the cafeteria every day and are very healthy. And so I was wondering, and this is just some case studies that I've been asking just friends who work in nursing homes. I said, well, are the ones in the bed who are bedbound, who are really the sickest of the sick, are they the ones who are dying from SARS-CoV-2? Or are the ones who are the healthiest, who are going to the cafeteria and socializing, are they the ones who are getting SARS-CoV-2 in the nursing homes? And my friends who worked in the nursing homes, again, this is a case study. I do not know how representative it is of nursing homes in general. There haven't been any reports that are published that I was able to find. But from these case studies, just talking to nurses working in these environments, their experience has been It's the ones who are the healthiest, who are going to the cafeterias, who are socializing with the other people. Those are the ones who are getting sick and dying. The ones who are bedbound are not getting exposed to SARS-CoV-2. They're staying in their bed. They're not going out and getting exposed to it. And so those are the ones that are not actually the ones getting sick and dying. So the ones that we cannot assume that the people who are the sickest are the ones that are dying early. It's just the opposite. The ones who are the healthiest are the ones who are most likely to be out and about walking, and the ones who are most likely to get exposed and get sick and God forbid die. And so this is just something we need to be aware of. A couple of other things that we can talk about. One thing that's come up again, this question of herd immunity. One place I like to continue to look for herd immunity is in the prison system. And the reason is they have no place to go. So for instance, I've heard estimates that maybe there's herd immunity at 50%, maybe it's at 60%. I read a study a week or two ago that maybe 20% of the population is all it takes to get infected, and then you have herd immunity. The problem is, if that were true, then you would see this in hospitals where there's no place for them to go. And the problem is, at hospitals, when you look at hospitals that have been reporting their data, a lot of hospitals simply are not. But some hospitals have upwards of 80% infected before they stop reporting. So we don't even know if it gets to 100%, if herd immunity is even possible. But what it means is that, so on average in this one, this was just a random one that the CDC reported on, 72% of the prison population was infected. So that means that in this case, herd immunity did not have any protective effect until at least 72%. Then that was when the report stopped, when they stopped taking the diagnoses. So we don't know if it ended up being more than that. And in some of the dorms, it was as high as 82%. So that means if we're talking about people going to school, if we're talking about people going back to the office, if we're talking about people going to community centers, and we want to see if herd immunity would actually protect people, it could be that 80% need to get infected to have protective immunity. And again, this is not a ceiling. This could just simply truly be a floor of what the herd immunity would need to be, because this is just the point in time at which they stopped doing the diagnostic tests. They could still be, if they were to go back and look at it now, that the numbers were even higher than this, higher than 70%, higher than 80%. So again, we cannot depend on herd immunity here. And so this is a tricky thing. We're almost at time. Let me see if there's anything else to talk about this week. I think I hit most of the major things I wanted to talk about. We can save other things until next week. Yeah, let's end it here. One more thing, I'll just talk about this briefly because it comes up, this idea of a iatrogenic exposure in the hospital. And again, it comes from, there's different ways of pronouncing it. In English, a lot of people pronounce it iatrogenesis, but in reality, the physician in ancient Greece, in antiquity, was called a iatros. So the physician, the iatros, was the sort of the wandering physician. And so back then, they would go to school, they would learn the craft, and they would, because they wandered from town to town treating people, that's why the staff was known. So the caduceus that you might have seen was this picture of a staff and a snake. That's where it came from, because historically, the staff was there because physicians were always wandering from town to town, and so they were commonly carrying a staff with them. Then similarly, the snake was seen as a very healthful animal. It was a symbol of good luck back then. And so if a person who was sick was visited by a snake in ancient Greece, then that was seen as really healthful. And so they would wish that a snake would visit upon them and that they would be cured of whatever their ailment was. And so that's why the caduceus has the snake and the staff. Interestingly, during the time of Hippocrates and for many centuries, there was a god of health and that people would pray to. And the god of health, his name was Asclepius. Asclepius was also called the serpent bearer. There's a constellation for the serpent bearer that you might see in the night sky. The serpent bearer, Asclepius, was Apollo's son. And interestingly, so Asclepius had a whole healing family. And so Asclepius had a daughter whose name was Panacea, who's the goddess of universal health. And now we have this term panacea in English. And what she did was she had traditionally had a potion which could heal the sick. They could heal any ailment. And so now we have this idea of a panacea in English. We have this idea of Hygeia. This was another daughter of Asclepius, and that's where our concept of hygiene came from. She was the personification of health and cleanliness and sanitation. Back then in antiquity, they understood that cleanliness and sanitation were really important for health. The daughter's name was Hygeia, and that's where our whole concept of the word hygiene comes from. There were a few others that didn't really make it into our common vernacular anymore. There was Yaso, who was the goddess of recuperation from illness. There was the goddess of the healing process, which was Seso. I don't know if I'm pronouncing these right. And then this last one that I certainly cannot pronounce was the goddess of beauty, glory, and sort of, again, the recovery from healing, back to beauty and splendor. But it's interesting. A lot of our terminology for health-related things comes directly from antiquity, from ancient Greece, and it's just really a fascinating thing. Anyway, I'm going to call it a day for now. Again, please send me any of your questions during the course of the week, and I can follow up with them. But thank you, everyone. It's been great, and have a great week. I'll talk to you next Sunday, same time, 7 p.m. All right, bye-bye.